If you need to have patients for your OSCEs or your clinical exams, you generally need patients who are young, have a condition that can be examined frequently without pain, and then that is relatively common, so it's not that difficult to find. And unfortunately, patellar dislocation and instability is very common. So for these then, we're going to go through the topic as we normally do. So the definition of this is a dislocation of the patella from the trochlear groove of the femur. So you'll hear about knee dislocation. You'll often hear it being referred from the emergency department to us or from the community as, oh, I dislocated my knee, which is a very serious injury and is very different. I dislocated my patella is certainly very different again, and it's not as serious. The incidence ranges, depending on what piece of paper you read, from 29 to 43 in 100,000, but very clearly it is a female dominant condition, something that happens a lot in females who have a lot of ligament laxity, and they generally may have a poor muscle tone and poor muscle bulk as well, especially in their anterior compartment of the thigh. The etiology can be trauma, as in you have simply been playing football, somebody slide tackled you when you're low to the ground, and let's say a studs up type of tackle takes your kneecap out. But congenitally, and what I mean by this is that if you have a high riding patella, if you have a shallow trochlear groove, or if you are also bendy like Ehlers-Danlos or Marfan syndrome, or you have high collagen content, and let's say there's some abnormality in your own collagen that can result in you being more stretchy. This is something that also happens. Habitual is a diagnosis of exclusion like anything else, and generally this is something that we see again in patients who have a lot going on. They might be generally lax from their ligaments, and also from a habitual perspective it does come under a very complex spectrum. This needs a lot of psychological input, a lot with the social workers, the physiotherapists, pediatrics generally, and also ourselves then as well. But in that case, surgery is rarely indicated for those patients. The signs are, in the acute setting, evident deformity, and it looks like there's a medial dislocation, but actually what's happened is the kneecap itself has gone laterally, making the femoral condyle on the medial side more prominent. The knee is often locked in flexion, or the patient feels that it's locked. Now, if it's chronic and there's an instability history, you'll have a positive J sign where the patella itself tracks downwards and at the end it can J. A high Baton score or hyperlaxity as well can be seen. Increased rotation is something that we see as well, or malrotation of the femur. Soft tissue conditions and muscle imbalance and reduced bulk. The symptoms will be generally that they feel it's unstable, it recurs. There's a lot of apprehension when they go through the range of movement of flexion. Pain is an obvious one, but instability and specifically descending stairs. Activity modification is something that they may say, I used to do X, I can't do it anymore, and I've adapted and I just don't do that particular activity or that particular job anymore. The clinical exam is vital. Head to toe, look at them, check what they're like. Are they bendy? Do they look like somebody who would have a high Baton score? Make sure you look up what a Baton score is and how you score this and be accurate on it. And then your other investigations. Plain film is a starting point for everything we do in orthopedics. The CT is for the rotational profile, and what that means is you get a CT from the femoral head down to the dome of the talus, and then your radiology colleagues will then give you measurements for the rotation. The MRI then is specific to the knee and is not the whole length of the leg. You get that for the cartilaginous surfaces. You can sometimes have what looks like a normal trochlea on a CT, but when you get the MRI, there's a huge cartilage bump which is forcing the patella out of the joint. Treatment-wise, generally it's non-operative. Activity modification, muscle strengthening, specifically for the VMO on the medial side of your thigh, and also in people who might fail that element, we can then move on to operative fixation, but we generally don't consider anything like this until they've exhausted non-operative management. You can then look at these from a soft tissue stabilization and reconstruction, or a hard tissue, by which I mean an osteotomy, but we generally do these in combination. And if you want to check out the FRCS video, you'll see some more detailed indications and details on this then. The prognosis is dependent upon the origin of the cause. If it's connective tissue disease, well, we can't change the genetics. If it's habitual, again, you have to break down that cycle. But if it's an osteotomy and realignment, we have a very good prognosis, because once you get that kneecap to dock into the trochlea, it gives you a nice, simple running track for that kneecap to run up and down the front of the knee, and therefore you are containing the bone of the patella within the track of the trochlea.